Hello. For the next almost 10 minutes, I hope what we're going to do is help to deepen your understanding of what we mean when we're talking about our patients who have febrile neutropenia. If you've not seen one before, this is a viewed in a microscope of a blood slide, and we can see a number of different blood cells here, and I'm going to focus our entire talk today on this cell here, which is a neutrophil. So neutrophils are cells that obviously float around in our bloodstream. They're made in the bone marrow. They can be found in the blood and in tissues and in lymph nodes throughout the body. They each have a lifespan of less than 24 hours, but your body's continuously making them and makes over 100 billion of these cells every single day. Their primary function is involved in fighting infection. Neutrophils address the foreign invaders that come into our body. They can do this by eating them, which is a process called phagocytosis. They can also suck them up into the cell in a process called endocytosis, and once the foreign organism is inside the neutrophil, it's treated with enzymes which result in the destruction of the organism. This might sound very similar, but they are by different pathways, both of which end up with an invading pathogen which is now no longer able to cause our body any harm. When a child gets diagnosed with cancer, they quite often begin chemotherapy and sometimes high-dose steroids. And these treatments can heavily reduce the number of neutrophils which their body has, and that can sometimes vary throughout the child's chemotherapy treatment. They might have 0 neutrophils for months and months. They might go through periods where they have normal neutrophil counts, and it's impossible to know for sure when they're going to have no neutrophils, which is the name we give neutropenia. So what we do is we tell these children, and when they're in Alderhay, they get the clear instruction by their oncologist that if there's any signs of fever greater than 38 degrees Celsius, it needs to be taken very seriously throughout the time of which they're undergoing chemotherapy. They all have open access to our ward, and they're told that they must attend quickly in order to be treated rapidly with IV antibiotics. Invading germs and microorganisms, they enter the body constantly, every day, throughout different entry points such as the nostrils or a cut on the surface of the skin. And actually a lot of our patients in this group have central lines. So this is effectively a cut in the skin which we've placed a piece of plastic inside of their body, which is always going to be a potential infection hazard. When these children have neutrophils present in their body, they would normally recognise such infectious threats and they work hard to destroy these harmful substances. But obviously the flip side is if you don't have these neutrophils, then the invading microorganism might have gone undetected, and now the child has a fever. It could be a sign that the patient has sepsis. Patients in this risk group, the children with cancer, they spend many months to years of their young lives in and out of hospital. And we inform the parents how important it is that they get to hospital quickly whenever they have fever. So it is really important that we as healthcare professionals also recognise the importance of quick action. Even if the patient isn't septic at that point, we still need to follow closely to the guidance and never take any chances. If chances are missed or treatment delayed, overwhelming infection can result, which can be very difficult or prolonged to treat. And of course, it can even end up with death. There is this guideline here attached to the back of the door in the green cupboard, which is our pathway of the summary of the management of the febrile patient from Alderhay Children's Hospital. I'm going to talk about that just now. So the plan is that if the guidance suggests that if there's any temperature greater than 38 degrees at home or in a hospital, assess the patient first. Are they shocked? If not, then we'll administer piperacillin/tazobactam, which is the drug commonly called tazocin, unless they're penicillin allergic. Tazocin is a beta-lactam type antibiotic. Piperacillin is a beta-lactam antibiotic, so we have to be very cautious if they're penicillin allergic that we should not give them that drug. Our nursing staff are often very excellent at taking the blood tests there and then for full blood count, CRP, electrolytes, lactate and blood cultures. Often it's from the central line that these children have, or if they have no central line, then they need to have it taken from a peripheral vein, put a hold on any oral chemotherapy and arrange for an urgent doctor review. Normally what happens then, the consideration has got to be that if the doctors have managed to isolate a source of the fever, for example, a viral upper respiratory tract infection or tonsillitis or chest infection, and then the child is found to have neutrophils on the full blood count which are greater than 0.5. We're also a bit worried about neutrophils which are under 1 and have been dropping recently. Then we may be able to stop the IV tazocin and discharge the patient with or without oral antibiotics. However, if we worry about a line infection, IV antibiotics will need to continue, and doctors will be in communication with Alder Hey to arrange the plan. As nursing staff, you might well be the first person coming in contact with these children, and you have to again ask, are they shocked? And if so, make sure you get help and manage as per the ABCD algorithm, which I'll talk about in another video. Still, you'll administer piperacillin/tazobactam as a first line. You'll also add in gentamicin, being also aware to check recent renal function before you administer gentamicin, because as I'm sure you're aware, gentamicin can be renal toxic. And consider tachyplanin if you think that the condition in front of you is line sepsis. Sometimes patients also require an antifungal treatment such as ambisome. Any immunosuppressed patient continuing IV antibiotics will do so until we have the cultures and the sensitivities back. Effectively, that means that the blood which is taken as soon as the patient arrives on the ward, it gets sent for blood culture. That means that the blood is placed onto a petri dish, and in the lab they place it inside of a machine that will warm the petri dish and alarm once the detected bacteria growing in there. If there's bacteria in the blood culture, that means there's bacteria in the blood of the child, and we'd be very worried about sepsis. Once there is bacteria growing in there, the microbiologist then checks that bacteria for sensitivities, which means they test that bacteria against a number of different antibiotics to determine if the bacteria is resistant or is sensitive to antibiotics. We get a report from the lab saying things like this blood culture grew a Staphylococcus aureus, for example, a bacteria, and it is sensitive to amoxicillin, and it is sensitive to clindamycin, it is resistant to trimethoprim, for example. They just have a list of different antibiotics to give us the chance to choose an appropriate one for the child. We often keep them in hospital until they've stopped having fever for at least 24 or 48 hours, and each day we're assessing carefully to make sure they are well. Our doctors will have daily discussions with Alder Hey to confirm plan. I want you to be aware, this cohort of patients really do need to have our full attention. They can sometimes feel like a quick job and we just see them, assess if they're shocked, start tazocin and walk away, but they have the very concerning ability to deteriorate rapidly despite being on IV antibiotics. Therefore, always treat them urgently and communicate with their caregiver regularly, as they will know their child best and they'll be able to tell you if their child is not like they normally should be, and if they are worried, we need to take that concern very seriously. Also, it's really important, again, back to the point that these children are in and out of hospital so often that we're not making them have unnecessary waits and that we're discharging them as soon as is safely possible. So, as always, let me know if you've enjoyed this video or if you have any questions. I'll be on the ward fairly regularly.